Hello, everyone. Welcome back again. Thank you for joining us this evening. I understand everybody's trying to get back to work and trying to get things back to normal. I'm very glad that we're no longer where we were. So it's exciting. I think it's a good opportunity to think about things and reflect. Reflection is everything. And to think about the things that you can make your practice stronger, make your scope of practice stronger too. I'm going to wait just a minute or two because I've had a few people say I think it's just a Zoom thing, and we've tried to get around it where I've started the webinar and a number of people have not been able, they join and there's been a lag in the time that they've joined in. But I'd also want to say a few things. As I said before, we have the boot camp. We've now got dates for the first weekend of February. So people that want to join, please contact us as soon as possible so we can have a look at numbers. And the whole organization will be based on the numbers. We have a bunch of people that have already shown very keen interest to join on. I will also go through a few things about enhancing and growing our community. We're also looking at having a internal private group as well on Facebook, where we have a platform where you can present some cases that you need some advice on, or just general advice. I'm always open to you contacting us through our email or giving us a ring. I am very busy. I'm so pretty much months advance booked up, but that doesn't matter. That if you have a valid question and you're part of my webinar group, we are a community, I will take the time and effort to answer your questions. I think hopefully most people should have joined by now because it's just after 7. And hopefully you look forward to this seminar and enjoy the seminar. The reason I put this one in is because risk assessment is everything. If you want to do things so that you eliminate that fear of things going wrong and what's in your scope of practice, then this is very, very important. Quite often, most of the cases, and I get sent a number of cases where to be honest, as I said, by my failures, I've been involved in cases where things haven't gone right, and there are people put certain things into process where they're legal or otherwise. This is going to happen to you as a dentist, and it doesn't matter if you're the best dentist in the world or the worst dentist in the world. This is just par for the course. However, if you can mitigate your risk and reduce the risk that you have, then that is everything. Ultimately, you want to show that you're operating within your scope of practice. So although implant dentistry is not a speciality, it is almost judged and governed almost like a speciality. So quite often where I see cases that are presented to me where they want me to preside over something a dentist has done, number one, I'm a firm believer in supporting our group and supporting dentists. I am strongly against people throwing dentists under the bus. If you see something that isn't correct or anything else, talk to the dentist, talk to the patient, see if you can resolve the issue. There's no reason for doing that. There's enough pressures on us as they are, and there's no reason for us to be all trying to sort of like backstab each other. We're supposed to be forming a good and solid and wholesome community, and this is part of the reason that we're sort of doing this. There's a need for it and a niche for it. So, I think it's better for us to walk along that path and support each other. If I have a case that I think hasn't been done to standard, sometimes things go wrong. They go wrong for me. Has the dentist been given the opportunity to rectify the situation? But more importantly, usually when I get asked about these cases, they ask me whether the dentist was practicing within their scope of experience and practice. And you need to be able to substantiate that. And if you can't substantiate that, then that becomes a problem. You need to know that, whatever you're doing, you're able to show that you've done before, you've had good learning behind, and that it's been evidence-based, and that's extremely important. You know, this will keep you out of most hot water. If you can see that you've basically done everything by the book and it's within your scope of practice and things go wrong, then that's normal. You know, we're biological. You're not putting wheels on a car. You're dealing with patients that are biological, and things can happen. But if you have a set precedent that you adhere to, that's been proven, tried and tested, hence the evidence-based part of things, and that's exactly how we work within our certification, our diploma, MSc, and even the boot camp, and everything we do, we try and make it completely evidence-based. So there is a basis on which, you know, we're standing on the shoulders of giants. It's not our research, and I'm very grateful to the people that have done this research. Without further ado, let's get started, shall we? There's not a huge number of slides. We're going to go through some very important slides, and that's why, and it's going to take some time, but I really want to instill in you, you know, some of the assessment tools. These are just two of them, and the ones that I'm presenting today are, one of them is SAC, a SAC classification. ITI do this, and ITI is a wonderful organization. I strongly advise you to join ITI. They have a massive resource of information. You know, most people say, you know, why are you promoting ITI when you run a course too? You know, there you can register. I don't see things like that. You know, where I see things are good and people are doing good, you know, I would happily promote that and advocate that. They are a great organization. They have a wealth of information and resources there, and they're at your fingertips if you become a member. They run some great courses. So one of the first bits I'm going to do is a SAC categorization and for criteria for you to not place or not place implants, and also for you to be able to classify your case in the SAC qualification. So we're going to go into that first of all. So let me just start sharing my screen, and then we can actually have a look at what the SAC qualification is in itself. So just before we start, I just want to go through again. This is just basically signing up, and I've said to you before that you know, follow us on Facebook, follow us on Instagram, share Facebook. You know, we're building community. You want to get people involved, and you'd be surprised if you're getting people involved locally, or you're sharing with your group or your friends, or if you're part of a Facebook group, why not share it? You're becoming part of a bigger community, and you'll find that people that are either your close colleagues or are near to you in terms of geography will give you support if you're part of a supportive group. And also, you know, if you fall into hot water or you find something difficult, I'm always open to people contacting me. If you want to treatment plan something, I don't charge for this. I usually do, because usually people have to come in, but you know, we're creating community. So if you have some cases that you want to talk through, and we can do it through Zoom, we can do that. And there's the best way of learning is through cases. So today we're talking about risk assessment in implant dentistry, and that's basically where we're going to be today. So I'm just going to show, first of all, the SAC classification introduction, and it just gives you an outline of their classification. They do have a tool which I strongly suggest you use. At my level, I pretty much know the tool back to front, and I still use it mentally, but it's good to have this, and you know, it's a great tool to use, and it will allow you to see whether or not you should do the case. And quite often people are saying that on the fact that, you know, they're I don't want to refer the case, I don't want to do this. Look, do what's in your scope of practice. Run a good, tight practice. Be happy with your dentistry. Sleep well. Enjoy dentistry. And the way to do that is to make sure that you are acting within your scope of practice. And the fact that, you know, you've learned this or that or the other about bone grafting or the other, and you're going to have a go, doesn't wash. Because if it goes wrong, and it goes horribly wrong, you don't have a leg to stand on. So if you want to do this well, just find out. And I am a firm believer, and I still do this, there's certain things that I can do very well, but I no longer want to bring into my practice. I'm not saying I'm the oldest, but I'm probably a lot older than a lot of you. And, you know, I don't want to be doing those things anymore. And I would prefer to refer them. And I'm a firm believer, if in doubt, refer out, and you should really hold to that. So let's have a listen to this.
The use of dental implants has become a standard treatment in many clinical situations. However, in order to achieve optimal functional and aesthetic results, the clinician has to assess the complexity and risks associated with an implant therapy before starting the treatment. The SAC classification system differentiates between straightforward, advanced, and complex treatments. It was first proposed in a textbook on minor oral surgery for general dentists. In a consensus conference in 2007, the ITI reviewed and refined the SAC classification for use in implant dentistry. The proceedings were published in a textbook in 2009, and since then serve as an important tool in implant dentistry. After completing this ITI Academy module, you should be able to indicate the purpose of the SAC classification, identify its determinants, identify modifying factors, and select case complexity using the online SAC assessment tool. The SAC classification is a flexible tool that can be employed in a number of ways. It can be used purely as a checklist to ensure that all of the important issues in the case have been considered. Airline pilots run through checklists every time they take off or land to be sure that they have all of the necessary aircraft settings correctly selected. The SAC classification can be used in a similar manner to make sure that everything of importance has been considered. Probably its most useful application is in determining which cases clinicians choose to treat and which they might prefer to refer to a more experienced colleague. This allows practitioners to develop their skills in implant dentistry in an incremental way, starting off with straightforward cases and then progressing to more advanced and complex treatments as their knowledge and skills grow. Finally, the SAC classification is a useful communication tool. It allows clinicians to describe cases to colleagues who are also familiar with the classification in a way that is quick and reasonably free of the risk of misinterpretation. It can also help in discussions with patients, offering a structured approach to discussing risks and potential areas of difficulty. This way, the patient is made aware of these issues and can consider them before making a final decision on whether to proceed with treatment. The SAC classification can be thought of like a traffic signal, helping clinicians to determine whether to become directly involved in treating a case or to refer it to a more experienced practitioner. With straightforward cases, the risks are low and the procedures not too difficult. In these cases, clinicians can proceed normally and do not have to worry too much about problems arising. Advanced cases present more risks and more difficulties. Some caution is indicated when treating them. Complex cases have the greatest risk and complexity. Even experienced practitioners might best stop, consider, and only proceed when they are comfortable that it's prudent to do so. Purpose of SAC classification, key learning points. The SAC classification is used as a risk management checklist. It assists in case selection so that knowledge and skills can be improved incrementally, and it assists in communication with colleagues and patients. The SAC classification for any surgical or prosthodontic treatment is determined by consideration of the aesthetic risk associated with the case, the degree of difficulty associated with the treatment process, which can be determined by considering the number and complexity of the steps involved in the treatment process, and the ease with which the outcome of treatment can be predicted. Finally, the risk of complications and their potential effects and consequences have to be considered. These three considerations will be described in detail in the following slides. Principal among the factors that determine the SAC classification of a case is the level of aesthetic risk involved. As patients will likely have only a limited understanding of the treatment that they receive, the aesthetic outcome is often their prime determinant of success. If an aesthetically pleasing outcome is not achieved, they will be unhappy, irrespective of how functional and durable the result may be. Aesthetics in implant cases are primarily determined by proportion and symmetry. If the implant prosthesis is to be indistinguishable from the natural dentition, not only must the prosthesis look like the corresponding tooth, but it must also have the mucosal height and contours to mimic the environment of the surrounding natural teeth. Thus, how much these soft tissues are visible when the patient smiles, talks, or interacts with others will determine the risk of a suboptimal outcome. A number of factors can impact the color and contour of the peri-implant mucosal tissues and can increase the aesthetic risk. The Aesthetic Risk Assessment, or ERA, was published in the ITI Treatment Guide, Volume 1. The aim of ERA is to help determine the potential level of aesthetic risk involved in a patient case. This is achieved through assessment of 12 clinical risk factors, where each factor may be categorized as having a low, moderate, or high aesthetic risk, depending on the description that most accurately describes the situation. The use of dental implants has become a step.
So this is basically one of the things that we're going to go through. It's the 12 sections and criteria in assessing a case. For example, we have this gentleman here who's missing a lateral incisor. Sorry, not left side, central incisor, the 2-1. And when we look at this case, so, the first things, when I went back to people who watched the first webinar program, the first 4 webinars, and if you haven't, go back and have a look on our YouTube channel. If you don't have access, contact us, because they're great. They give you a synopsis of complete assessment of a patient. But I want you to start looking at things differently. When you look at a case like this, you want to look at the case and see, what do you see just from that picture? What do I see? Where is a smile line? It's low at the front, but it's low at the back. No, it's not. What kind of biotype does the patient have? What type of occlusion does the patient have? Do you see any wear anteriorly there? Do you see any fractions, any erosion? Do you see any parafunctional clues? What is the form of the teeth? And what I mean by bioform is the morphology of the tooth, whether it's square, rectangular, oval, or triangular. In places where you have triangular teeth, you have longer papillae, and when you lose a tooth, it's the bone around the papillae area and the loss of papillae that you're trying to basically get back where it was. And those papillae are difficult to re-establish because the bone is gone. And as I said to you before, a soft tissue is the issue, bone sets the tone. So if you can't do that, how are you going to deal with a case that has triangular teeth and you're likely to get a black triangle? So I'll show you, there are clues you can see. This patient was wearing a denture. And what I look for on the denture, not the actual palatal part, if you look at the part beneath the actual ridge, there's a fair bit of pink there. And that pink represents the loss of tissue. It's an indication. It gives you a loss of bone and soft tissue, and gives you an indication of how much has been lost. I'm a firm believer in trying to return things back to the way they were, and that's not always possible, and that's not idealist, because if you do return them back to where they are and you then put implants where they should be, you will end up with having control over the aesthetics of the implant. And if you're as old as I am, going back almost 3 decades, into implant dentistry, when we started out, we had, we didn't have these sort of SLA and other treated surfaces. One of the first implants I started using was a polished implant, and it was very successful. It was a Brandenburg implant. And, going back then and looking at things the way that they were and the way they are now is completely different. You want to set up an ideal situation. You'll see that implants have started to become more and more like the root of a tooth. More and more tapered implants are used, and that's, in hindsight, common sense. I want to just jump out of this for a second and share a different screen with you and show you the CBCT for this patient. So this patient came in to see us, and I'm going to just show this CBCT so you can actually have a look at this very clearly. This is CBCT for the patient when they first attended. We'll go through the 12 criteria in a moment, but I just want you to have a look at what we see. So looking at the actual photograph there, not saying that you limit yourself to that, but if you had to look at it at a glance, it looked like the tissue level was quite good, so you assume the bone level was. But looking here and looking at that tooth, you can see there's complete loss of the buccal plate around that tooth. And even if we have a look at it from this area, although there looks like fairly decent bone, you know, you could possibly place an implant there. You would have to augment around it. It's not ideal. Okay. So if we exit that and have a look at the actual CBCT and I go to the area of interest, here we can see in this area, let's pick a good slide so you can have a look. This area here is basically the section through that central incisor area. Now, one, we've got the incisive area there with blood vessels and nerves in that area. You've got a resorption of bone in the area on the buccal plate, and most of the buccal plate and the rest of the area is missing. And ideally, I want to re-establish this. Now, I don't only just want to re-establish this because I want to get the correct height and gingival aesthetic line, even though the patient has a low lip line. My view is always treat it as if it's a high lip line and try and aim for ideals. We want to establish that buccal fullness as well, because as I said again, bone sets a tone, soft tissue is the issue. You've got to work with the bone first. You've got to get the bone right. You cannot pump up the soft tissue to an extent where you mimic the ideal situation and revert back to where the patient was prior to having tooth treated, removed, or otherwise, without addressing the bone. So with these cases, what we did here was we took the patient and we involved ourselves in having a bone graft. Obviously, we had to talk to a patient, saying what that would involve. And after talking to the patient and talking through the procedure that we actually used for this was a procedure that is a defect style of guided bone regeneration. And what we did here was to take the area, and we did a bone graft prior to that. And what we did was to basically build the buccal and the socket area with a mixed bone. We used autogenous bone from the patient using a bone scraper and a bone donor. We used allograft. The graft that I used in this situation was the Straumann bone, and we used a Jason membrane also provided by Straumann. So I like to go back and show you exactly what the results were. So if we go back and have a look at that, this is post graft. So I just go back to the area of interest again. And I like showing these more of a sort of live situation. And this was our result post grafting. You can see along there the older part of the area that we originally started with. There was a little bit on the buccal side, but not much. The whiter radiopaque area is basically what we managed to graft. And we managed to probably get about maybe between 4 and 5 millimeters height and probably a good 5 to 6 millimeters width. And the point of this is the fact that you can turn a case that is complex or even advanced below that, in the Sac qualification. So straightforward, I prefer to use simple, advanced, and complex. I would regard this as an advanced case as opposed to complex. So a smile line is low, so there's a lot that you can get away with. However, it's bordering on the complex case because you need to have ideal bone levels to be able to do that. Okay. With these cases, again, you need to make sure the patient understands that the bone grafting is somewhat unpredictable. It's not unpredictable. It is predictable, but somewhat unpredictable because it's not as straightforward as placing an implant. And one of the main criteria we use, which we're going to have a talk about today, is the aesthetic risk index. And this is the aesthetic risk index. This one was adapted by Stuart Harding. Stuart Harding is the professor on our certification, diploma, and MSc course. Again, a few people have asked about whether they can just do 1 year, 2 years, 3 years, up to you, whether you do certification, 2 years of diploma, and 3 years a master's degree. It is part-time. The academic part is 90% online, which is evidence-based with Professor Harding. There's set topics. There's no actual formal examination. It's reflective notes because we're all now experienced clinicians. You don't need to be so under that duress. And that continues in the second and third year. So it requires very little time out of practice. But he is the professor on the course. And this is how this works. So you have a score. And this is sort of like the traffic light system where you have green, amber, and red. And you're considering the factors that are involved in replacing or putting an implant into the aesthetic zone. First and foremost, medical status. If you've been through the webinars that we did prior to this, I go extensively into medical history, medical status, and what to do in each situation, when to treat, and when not to treat. So ultimately, that will put you into 3 categories: a healthy patient with an intact immune system, a reduced immune system, or systemic illness with related gingival factors. And what happens in each one of these, when you click onto these, you basically will come in and you'll give a score of 1, 2, or 3, high, low, or medium. We use this in our practice the whole time. We go through this extensively in the boot camp. So if you want to know basically beyond the basic assessment, which we'll be going into fairly extensively, as well as aesthetic risk, and we'll be touching even on stuff on 4-on-4, whether you're doing it or not, just to give you a scope of things. And then we'll be going into drilling protocols and how to get guides planned and set up. So you pretty much have a kit on how to start placing implants. And what we're trying to do is allow you to place implants in a simple anterior region or a single implant, a posterior implant, and implants in a small space. Smoking habits, non-smokers, light, heavy smokers. You need to be careful of this. You need to make sure that you give them support and an opportunity for cessation. That's actually a requirement. And you need to make sure that you're doing that and log that you have actually asked them to do that. Right? Do I treat people that smoke? Yes, I do. But I make them very aware of the complications and the risks that they have from implant treatment with smoking. If they're a very heavy smoker, I'll be more reluctant to do that. I don't want to bring that into my practice. I know clinicians that actually do treat those patients. It's a bit like somebody said to me earlier, you know, if a patient was obese, would you deny them treatment at a hospital? Look, it's not quite the same, but you know, you want to be able to help the patient in their general health. Ultimately, with bigger cases, I especially put the full mouth rehabilitations, jaw resectioning, and large bone grafts, and simultaneous grafting and sinus lifts and other things. I prefer that they're not a smoker at all. And then we usually liaise with them and their GP to make sure that they can stop smoking. My rule of thumb is to see whether they can actually stop smoking for 3 months before I treat them in these big cases. A lot of these patients tend to rely on one of the, not the saying I'm advocating this, there are other ways of doing this, but the one that seems to be popular amongst patients, just from my experience, so take it with a pinch of salt, is Champix. So, and smoking does have an effect and a percentage risk on your implant treatment, and the patient needs to be made aware, and you need to tell them. The smile line, well, that's fairly obvious. You know, with a high smile line, there's no gingival tissue exposed, only teeth seen, as you saw in the last picture. So it makes it a low on that score. And you have to remember, throughout this, although the number may be low, there may be a number high, and that takes it into the high score. slight gingival exposure limited to the anterior. To me, this is just as risky as doing high gingival spine line extends to the molar region, because patients don't care if it's just the anterior what matters to them. I get many patients who come for full mouth rehabilitations and they have no posterior teeth, sometimes just 3 to 3 upper and lower. And the only reason they've come in is because finally one of those front teeth have gone and have failed or have a poor long-term outlook or prognosis, and they now want to do something about it. So they're very aesthetically driven. History of the site, the reason for the tooth loss. Was it trauma? If it's trauma, we want to know how the tooth had trauma. What happened? Was it evolved and put back in? Was a buccal plate broken? Did they have an infection? Is there a large area and loss? And it failed, a root canal treatment or a split root. With a lot of these cases, if there's a small, chronic, long-standing infection and we can actually remove that, and I not only curate, irrigate, and use certain solutions to reduce the bacterial load, we also use certain bits of equipment which are absolutely ideal to remove that granulation tissue and that infective tissue from the area, so we can have clean, healthy bone. And if we achieve that, we can then place an implant immediately. And this is something that you need to consider. Was the tooth loss within a year? Minimal trauma during extraction, so that's the medium. And tooth missing several years, history of trauma, surgical procedures, and severe infection. With the surgical procedures, this generally tends, in my world, to be where an apicectomy is being performed. I'm not a big advocate of apicectomies because if you look at the stats, they aren't great. It's not sort of modern dentistry, and ideally, even if they want to keep the tooth or whatever it may be, I think there are other solutions to that. The patient's aesthetic expectation, these are all general factors. They're primarily concerned with function, with aesthetics being secondary. Balanced aesthetic and functional requirements, primarily driven by cosmetic concerns. I can tell you now, regardless of what the patient says, they're always a high 3. We have patients that come in and, their teeth in terms of an aesthetic is very low on a 1 to 10, probably 1. As soon as we give them, even like, for example, when we do full mouth rehabilitation, we give them a provisional set of teeth to wear for 3 months while the implants integrate, and we put in the permanent set of teeth, they suddenly become very aesthetically aware and very aesthetically demanding. Somebody coming in where they had maybe 1 or 2 teeth anteriorly is now talking to you about you moving a lateral 2 millimeters measly because not happy with the aesthetic. So, I put them into that category. Next are dental factors. Okay, so also, equally as important, you have to see if the infection at the implant site to see if there's immediate replacement, and I've discussed that. If there's none, that's great. That's much better. Chronic is not as good, but still better than acute loss of bone and soft tissue destruction. And there's acute ones are where you want to be careful of. People say immediate implant because it has a bone around it, can take the tooth out. That's not the case. If it has an acute infection, you want to stay away from it. There are aggressive and active bacteria there that are virulent. You're placing a sterile implant into that area. Where do you think, just by the law of energy, things go? They will jump onto the implant like no tomorrow. So that's not what you want to do. And in those type of cases, I definitely clean out. I definitely make sure I graft, and I definitely make sure I come back to it. And if the grafting is not required, I will clean that out and come back to it and do a delayed procedure. Width of a denture span, 1 tooth 5.5 to 7 millimeters, 1 tooth 7 to 9 millimeters. Now you're sort of getting into an area where it's difficult to restore in that anterior area. That tooth is slightly bigger than adjacent teeth, and in these cases where we may have to treat adjacently to the site and the space to try and spread that additional space amongst the other teeth. Predominantly people tend to choose veneers, and if the teeth are heavily restored, then we would use a crown. And when it's 9 millimeter or 2 teeth or more, avoid adjacent implants. The reason that people tend to avoid adjacent implants, not saying that I haven't done them, but we will prepare the area so that it's ideal. And as I said before, we turned that case that was probably advanced stroke complex back down to simple stroke advanced. I'd actually even say simple, because he had a biotype 2 tough rugged tissue, low lip line, had ideal bone conditions. We could place the angle of the implant where we wanted to. We could platform switch it, and we could also get the right emergence profile. So tooth position, and the reason, sorry, they don't place them next to each other is because you can't reestablish those papillae. So quite often you get a very flat papillary area, and those teeth tend to have dark triangles. If we can actually get to a point where we can place implants with the emergence profile, where we can actually embrace and actually fill up some of that black triangle, then we do that. Right? Most of these cases will involve one, a bone graft, sometimes two. Secondly, they will involve soft tissue surgery for sure, connective tissue surgery, getting keratinized tissue around the area, and then having temporization that allows ideal scalloping so as to mimic a papillae. The tooth position regularity, the regular tooth alignment, size and level, class 1.5 to 1, well, 1 to 2 slight crowding, irregular and severe crowding. In crowding, that's a bit more difficult. The restorative status of the teeth. You need to make sure that if you have an adjacent tooth with root canal treatment, especially in category 3, the high risk is that you need to make sure that is successful. Because again, just like putting an implant into an affected area, bugs will travel towards the implant. And if you've got a residual infection around an implant, then root canal treatment adjacent to an implant site, you place an implant there. Not all the time, it's not super common, but I've seen it happen more times where you will get a transfer of the infection, tracking of it towards the implant. So you need to be aware of that, and that is a responsibility that you need to have. You also need to check the vitality of the teeth either side, because if a patient comes back and says you placed the implant and you killed the tooth next door, even if it's not touching well away from the surgical procedure that you did, lifting a flap or whatever it may be, you need to make sure that you have vitality there. And if it's non-vital, you can address that before it happens. The bioform, I discussed this earlier in basics, to the flat, medium or high, is in triangular because of the black triangles, oval and rectangular because there's more of a papillae, and square almost mean to be where there's virtually no papillae and they're square next to each other. So soft tissue factors. The biotype, low, scallop, thick, type 2, a type 1.5, if you're not aware of that, that's somewhere in between the two. If you look at it, you can't distinguish whether it's 1 or 2, then it's a 1.5. And high scalloped and thin. The type 1 tends to be prone to recession. It's very delicate tissue. There's a different way of treating it. There's different sutures I would use. There's different technique. Thick scallop tends not to recess, tends to get this type of thing where you see people with still a good gingival level and they've got these deep pockets. Okay, it's far more hardy and rugged. Pocket depths of adjacent teeth. Realistically, you need to make sure that the patient is periodontally sound before you place. At the very minimum, if someone comes in, and for me, it's a lot of referrals, and a lot of people come in referral, or people coming in directly just to have implants and not a regular patient that we have checkup and cleans on. We will always do a quick BP or CPIT and chart just to see what's there. And if there's existing periodontal disease, they can either go to their local dentist to have it treated. If not, then I will usually refer it to one of my associates, and they will take care of it. The height of the existing papillae and evenness, right? So short papillae, normal papillae, long papillae, or absent papillae is obviously the difficulty, because you're going to be replacing those and going back again, the papillae disappears. Soft tissue health and amount of gingival recession. Intact soft tissue, no recession. Intact soft tissue with only slight recession, and soft tissue defects and recession greater than 1 millimeter. You're obviously acting in a zone where there is recession. You can also stimulate further recession around teeth, and you need to put that into your consent and risk part of it. For people that did attend those 4 pillars of introducing implants into your practice, which I did at the very beginning. And we started with this webinar series. And please, if you don't have access to those, contact us, because you can have access to those. We discussed that in great detail. Okay, hard tissue factors. Condition of the residual alveolar ridge at the site. It's the ideal alveolar ridge with a crest bone deficiency. There's none of it at all. Good interproximal height of the bone, or there's horizontal bone deficiency, or there's vertical and horizontal bone deficiency. ITI have a wonderful volume on this, on immediate placement of implants, and one of the things they talk about is classification of those types of bone defect. We cover this, I think, in the first year in the certification course, we cover this, and we do advanced bone grafting step by step in the second year in the diploma, and we go through all of this. So, if you have a site that's ideal, then treat it. If you don't, treat it so it is ideal, and if you can't treat it, you don't have to refer the whole case out. If you've got a good mentor and good clinician, if you come to me and you had a case, we could convert that. I could quite easily do a graft and convert it back to being a simple case. Okay. And then the bone zone, the radius of bone at the implant platform. Ideally, the literature says that you need 1 millimeter, but ideally you want to go for 2 millimeters on a special buccal plate and a good bone zone. If you've got less than that, then I would think of using a narrower implant and augmenting. And if you've got a severe buccal dip and buccal bone width is less than 1 millimeter and there's inadequate bone zone, then you want to think about doing quite a decent graft. So the rest of the aesthetic risk index, after you filled in all of these categories, 1, 2, or 3, will put you into one of these, and it will basically churn out a 1, 2, or 3. So it allows you to see there's a predictable soft tissue aesthetic outcome. That's 1. That's easy. So that's a simple case. Acceptable outcome advise patients that they may have to accept some compromise in soft tissue aesthetics and some reduction in papillary height and unevenness of the gingival margin. You need to put that in there. Unpredictable soft tissue aesthetics, poor result, and implant site likely to require extensive regenerative growth processes prior to placement. Aesthetically demanding patients should be avoided. Consider conventional alternative. Compromise result may have to be accepted. They're all aesthetically demanding. Remember that. In our consent, if you see again in that 4 pillars we did consent. We went through consent very extensively, and people had access to my consent. And use it as you will. We don't have the liability or responsibility of that. That is up to you what you use. I'm sorry about that in the background. That's my dog. The aesthetically demanding part of it, they're all aesthetic demanding, and what we just basically discuss with them is that we make sure that they know that there is a potential for having either a longer tooth or having the use of pink porcelain. Now, I don't like using pink porcelain, but sometimes we have to use it. We haven't got the result. Patient doesn't want to have any more procedures and wants to have the tooth, and they want to have an implant. In those cases, what's important is for us to demonstrate the difficulties and the complexities of maintenance and aftercare around it, flossing it, keeping it clean. I almost treat it like a full mouth rehabilitation process, where the prosthesis of bridge, we remove 6 months and 6 months in the first year, and then yearly. In those cases, don't remove as much, as long as the patient's keeping it clean. I can see that there's on their reviews, no problems. But if there are some problems, we obviously go through a whole oral hygiene regimen. And if I see that's not being not adhered to, sometimes it's a case of motivation and their manual dexterity, then quite often we'll get them in to have that prosthesis, because I prefer screw retained, removed, cleaned, the area cleaned, the implant checked, the tissue checked, the abutment checked, and everything put back again. And that's a much better way of actually managing that. So that's a fair bit on risk assessment. I'm just going to stop sharing my screen for a minute. If you have any questions, please do let me know. Thank you for taking the time to come to the webinar. As I said before, like and share us on Instagram and Facebook. Contact us if you want to come into the practice. Sign up for the boot camp if you really want to get into implants. If you're placing implants, it's a great way of revising things in a really compact and concise way. And come and talk to us if you want to get on board with the certification diploma and MSc. The registration will be starting very soon. There are limited spaces only because we try to keep the group small. And unfortunately, if you do miss out on a space, we have to put you into next year. We're not running it concurrently with another group in tangent. So let us know. Sign up as soon as you can if you are genuinely interested. I'm sure most of you are focusing on getting things back on track. But the MSc starts next winter. I think our cohort is either, I think it's June or July, one of those. I'll get back to you. And our boot camp is the first week of February. I look forward to seeing you next week. Stay safe and take care. I hope you've enjoyed this.